Good morning. Thank you for joining PHCA for today's webinar, The COVID Catalyst, How Skilled Nursing Providers Prepare for What Comes Next. I hope everyone is doing well and staying healthy during this ongoing challenge with COVID-19. We recognize the extraordinary work that you've been doing throughout the crisis, and thank you for all that you're doing. I'm Wendy Johnson with the Pennsylvania Healthcare Association. Before we begin, I have a few housekeeping items to cover. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and to gain a better understanding of practical application tools to equip you so that you may continue to provide the highest level of quality care possible. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for 1 continuing education credit for PHCA members. Credits will be uploaded to NAB within the next 2 weeks for those who have provided us with your unique NAB number, and I will be sending attendance certificates. A survey will be launched at the close of the webinar. Your feedback is very important to us and our speaker, so please take a moment to complete the survey. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit your questions using your questions pane on the right hand of your screen, and our presenter will address them at the end of the presentation. Today's webinar will be presented by Ellen Kuebrich, Senior Director, Quality Solutions with HealthStream. I'll now turn the webinar over to Ellen.
Thanks so much, Wendy, and I really echo your sentiments. Thank you all so much for taking some time out of your schedules to hop on today. And it's been a rough, almost a year and a quarter now, and really want to thank you for everything that you do for our frail elders, and you're so appreciated and valued, and I hope that you hear that more often than not. Let's get started. We're going to talk a little bit today about how COVID has acted as a catalyst. I want to introduce myself to you all. My name is Ellen Kuebrich. I'm the Senior Director of Quality Solutions for HealthStream, as Wendy mentioned. And I've been working in the skilled nursing industry for about 13 years now. And I've seen, regulations and requirements change just about as much as you have, I'm sure. But I've really spent a lot of time consulting for skilled nursing and long-term care agencies, hospitals, and acute care organizations as well. I'm really showing them how to navigate regulatory challenges and quality challenges. And so a lot of what we're going to talk about today will probably have a little bit of a regulatory and a quality spin on it. So over the next 45 minutes, we're going to look at some of the big challenges that you're facing right now, and ones that are probably driving a lot of initiatives for you in quality and compliance. We're going to dial in on 4. So the first is how COVID has really exposed the frailty of our healthcare payment system. Then we're going to look at the repercussions that we can expect to see from our new administration, presidential administration. Some things that we think won't go away once COVID subsides a little bit, things that are probably going to be lasting changes. And then how you can take advantage of some of these things that are going on in the industry to really survive and thrive after COVID. So this, I know we've had a lot of webinars over the last year that are a little doomy and gloomy. I think we've all had enough of that. So hopefully this will just make you aware of some opportunities that you have moving forward to really boost census, to improve quality, and to have a better relationship with your referral partners. So let's start with what's probably the most fun topic, how COVID has exposed the frailty of our healthcare payment system. I wanted to start with a quote by Dr. Vivian Lee, and she's talking about our fee-for-service payment system. And she says, you're rewarding providers for performing services. And actually, in many cases, you're awarding that money regardless of whether the service actually improved a person's health. So as long as you do a lot of procedures, as long as you poke and prod patients and do more and more, the more money you make, until a global pandemic hits and people can't come in to get those services. So when we talk about fee for service, COVID's shown a spotlight on multiple ways that this system is problematic. In the traditional fee for service payment model, private health insurers, like you may have Blue Cross Blue Shield or Aetna through your private work employee health insurance, and then also government programs like Medicaid, Medicare, Medicare Advantage, They reimburse physicians and healthcare providers for the number of services that they provide. So every patient visit gets a fee. Every evaluation, we bill a fee. Treatment, fee. Procedure, fee. Test, etc. They're all billed by the provider to a third-party payer for payment. So inherently, this fee-for-service structure leaves both the medical provider and the patient kind of absolved from fiscal responsibility. As a patient, I'm not paying for it other than my copay, and the provider is really not seeing penalties or less payment if the service that they provide doesn't work. If I don't do a great job treating your pneumonia at the hospital, I get paid the same amount as if I had done a great job treating your pneumonia. So that arguably encourages overutilization by both parties, both providers and patients, and that leads to an increase in overall healthcare costs over time, which is why we always hear politically that healthcare is one of the largest expenses that we have as a country, and we don't provide healthcare for everybody. But it's because that fee-for-service program really encourages overspending. So the second issue that we have is that with COVID, almost all of us had our ability to charge fees for services come to a stop. People weren't able to get elective surgeries or do preemptive testing, which meant that reimbursement really dried up. You'll also hear tons of stories, though, where people were so afraid to go into the hospital last year, both for fear of catching COVID, but also with a sense of social responsibility of, I don't want to take up a bed if they need these beds desperately for these COVID patients. People weren't going in for things like heart attacks and strokes. So I pulled back in June a lot of publicly traded stock prices for 4 or 5 large health systems. We're going to look at them in a moment. And you'll notice that their trajectory is nearly identical. So on the acute care side, Sutter Health lost $1 billion in Q1. The Mayo Clinic was reporting that they were losing $300 million a month. You all know, all of our post-acute organizations, we weren't getting residents because no one was getting acute care. There wasn't a need for post-acute recovery, and we weren't getting long-term care residents because people were trying to keep them at home to protect them from getting COVID. So this is pretty typical. If you look, this is Tenet Healthcare. You'll see right when everything kind of hits mid-March, tanks down, and it really struggled to recover. When we look at HCA, which is the largest holder of hospitals in the country, it's the same identical curve. Same with Universal Health Services, which is another big chain. The American Hospital Association has projected that total hospital revenue in 2020, so last year, was at $323 billion. And they're saying this year, they could still be down between $53 billion and $122 billion from pre-pandemic levels. So if you're not in healthcare, kind of the natural response is, well, didn't they have the CARES Act to take care of them? And yes, the CARES Act did provide some funds. But if we look at those projected losses in 2020 of $323 billion, and then the total CARES Act was $175 billion, and hospitals really only got $54.6 billion of that, it's nowhere near helping them to recoup their losses. And let's keep in mind, I think we all know as an industry, hospitals really do get the lion's share of those incentive programs. So when you look at that $102.6 billion of the dollars dispersed to all providers, that's split up between everybody else along the continuum of care. So the amount of CARES Act dollars that we got as skilled nursing was not substantial enough to cover what we lost. SNF saw an $11.3 billion decline in 2020 due to occupancy. And that was coupled with the cost of the fact that we had to care for existing residents that skyrocketed in general. But then when we look at COVID patients, we just weren't getting reimbursed enough to keep up with the care that was necessary. So they think that we've lost about $57 billion last year. And in this coming year, AHCA's projected that skilled nursing facilities are going to lose a total of $22.6 billion, mostly because occupancy, the primary driver of income for us, remains at record lows. So keep in mind, I promise you, this is not going to be all doom and gloom. We've got some solutions here that are coming out that you're going to be able to take advantage of. But as an industry, as a healthcare industry, we really got hit hard, and we got hit hard being the ones that were fighting on the front lines this pandemic more than any other industry, and we're the ones that are taking the loss for it. So that's kind of a gut punch. And it really tells you, yeah, our fee-for-service program didn't work all that well. So the final flaw that COVID exposed was that fee-for-service as a payment system doesn't really lend itself to encouraging whole person wellness. So what does that mean? Well, most Americans access healthcare through the fee-for-service system, either through private insurance or through Medicare, Medicaid, Medicare Advantage. 6 in 10 Americans has at least one chronic disease, so heart disease, cancer, diabetes. 4 out of every 10 Americans have 2. And we know that COVID was particularly deadly to those with pre-existing conditions like chronic diseases. And many of those chronic diseases are brought on by poor health, obesity, smoking, alcohol, stress, lack of exercise. And it's really just evidence that our fee-for-service health system doesn't do a great job promoting whole person health. They're not really worried about trying to get people to quit smoking in any real way or getting them to drink less or work out more. And the reason is that with fee-for-service, there just isn't that financial incentive. That's not how our payment system works. So there is another alternative that you all are probably familiar with called managed care or capitated payment. So under that model, a managed care provider is going to get a per member per month payment, and they have to use that payment to provide care for the individual enrolled in the managed healthcare plan. So think of this like a gym membership. It costs you $40 a month, and the gym doesn't care if you come in 3 times a day, 3 times a week, 3 times a year. You're still paying $40 every month. Now, if you are only coming in 3 times a year, they're probably profiting off of your $40 a month, more so than somebody that's coming in 3 times a day, but it evens out. So in that model, managed care providers want to keep you healthy. They are striving to exceed defined standards for quality and efficiency, because if they're successful, they get to keep any of that leftover monthly fee. So in theory, this payment structure encourages providers to consider preventive health measures when they're addressing patient needs. They want to keep you well through things that don't cost them a lot, like physical checkups, annual checkups, weight loss programs, vaccinations, discounts on gyms, that type of thing, because they will avoid a bigger cost from you having a chronic disease or an emergency event like a heart attack later. So all this to say that managed care is recognized as a performance-based payment system, meaning if you perform better, you'll probably make more money. If you perform worse, you'll probably make less. So now let's take a look at Anthem. So this is Blue Cross Blue Shield, and you'll see that they too took a hit right when everything started, but look how much more quickly they rebounded in terms of their stock price. It's just a much more predictable model for cost, and it's really been proven to see better outcomes than fee for service. So what's the fallout? Is this going to change how healthcare providers are paid and we're going to move to a managed care healthcare system? No, absolutely not. Not anything can change overnight, and healthcare in particular moves really slowly. But COVID has acted as a catalyst here. So things called value-based purchasing programs or pay-for-performance programs are considered almost like a stepping stone towards performance-based payment that don't completely upend healthcare and how we're paid. So you should expect some of these initiatives that move fee-for-service organizations towards value-based payment to pick up support. That would mean things like bundled payment, where we pay out a lump sum for an entire episode of care. Just to throw out a number, it's $25,000 to care for somebody with pneumonia, and that $25,000 has to cover the hospital stay, the skilled nursing stay, home care, physician, pharmacy. And if we provide care efficiently, get them well quickly, and there's money left over from that $25,000, we split it as a group, right? We profit share. You'll also see an acceleration of value-based purchasing or pay for performance. And those are programs that pay you more or penalize you based on outcomes. So these exist today already. I'd expect to see them expand. Both hospitals and skilled nursing facilities are getting penalized for having high readmission rates. Hospitals are incentivized for high customer satisfaction outcomes. So all this to say, because hospitals lost a lot of money in 2020, I would expect, if I were running a hospital, I would start scrutinizing all the ways that I can make more money this year and lose less money this year. because they're getting penalized for things like readmission rates, because they're getting incentivized for things like high customer satisfaction outcomes over the total course of a care episode, they're going to be looking at you. They're going to be looking at their post-acute network. If they're getting penalized because of readmissions, they want to know which skilled nursing facilities aren't sending people back. If they're getting incentivized for customer satisfaction, they want to know, which home health organizations have high approval ratings, because those will be reflected in their scores. They are looking for post-acute providers to perform well on their annual surveys, to have high 5-star ratings, to be able to provide quality metrics that would affect their bottom lines, like length of stay, readmissions, customer satisfaction, community discharge rates. They're going to look for the places that prioritize quality, and you want to be on that list. If the hospital isn't sending people to you, you're out of business. We're all down on census right now. So we have got to be very strategic in how we have a plan to increase our census from what it is today. If the hospital isn't sending people to you, you will be out of business, and we've seen that happen already. So the other thing to look out for is really when new operators are taking over nursing homes, and you all are probably more aware of this in your areas than anybody, or if you are a new operator taking over a new nursing home, really looking into what is the reputation that you have now and what is the reputation that you want to get to, and how are you going to get there. So how do you get into that network? I really want you all to think of this as an exercise in having knowledge of the competitive marketplace, setting your messaging apart from your competitors, and appealing to their sense of financial responsibility. So gone are the days where we'd walk into a hospital and try to find them and drop off some donuts and some brochures about our great rehab services. You may still do that. That's not going to be as effective as having a financial argument for why you should be in their network. So what are the things that they look at? 5-star. I'm sure we all have our own opinions on 5-star. It's not really the most accurate rating system I've ever seen. I've been in 5-star ratings that I wouldn't put or 5-star facilities I wouldn't put my grandmother in, and I've been in 1- and 2-star facilities that have really great care. They just got hit with a hard survey 3 years back and maybe have an older building. So it is what it is, though. We still need to be aware of it because the public can see it. Hospitals are definitely looking at it, and it's being considered in value-based purchasing programs. So when we first looked at accountable care organizations, the official ones, which there were a lot of unofficial ones, but in the official ones, a nursing home wasn't allowed to be in that initiative unless they were a 3-star facility. And that message has kind of gotten out. David Grabowski, who's a professor of health policy at Harvard, was talking about in healthcare, and he said, that's the new reality. You can't play here if you're not a 3-star facility. So be aware of what your star rating is. Now, we're going to talk in a little bit about how you should have knowledge of who else is around you and what their ratings are. But I don't think that if you are a 1- or a 2-star facility at this point that you should feel like you are down and out and there's no way. What you should do is take a good hard look at what your plan is to get to a 3-star and be able to effectively share that plan with your referral sources at the hospital. If it is the fact that we had a really rough survey 3 years ago, but here are the measures that we've put in place so that that doesn't happen again. Here are our survey scores for the last 2 years. You can see that we're trending towards, once that falls off, we'll definitely jump 1 or 2 stars in our ratings. And we want you to be able to take advantage of our high quality and our efficiency now. That's a way that you can get around the fact that you're not 3-star yet, but we are aware of what we are doing. We're aware of how we get to the next level, and they can take advantage of your good practice today. They will be looking at your survey results. Surveys coming back with a vengeance, and frankly, Pennsylvania has always had some of the toughest surveys in the country, as I'm sure you know. Everybody was already on a backlog before COVID hit. I mean, we were stretching survey windows nationwide before COVID hit, and then everybody got, a 9-month break from surveys, and really it's turned into almost a 12-month break at this point. CMS is starting those surveys. I heard in Ohio they started last week full force. Pennsylvania and Ohio kind of run together that way. So I would expect that surveys could be coming back. I don't know how they're prioritizing folks. I know that if you have active COVID cases or a new outbreak, they're still probably going to be looking at you, but they won't just be doing that COVID specific survey. They're going to be doing the full one. Other than that, my guess would be that they're going with who has had the longest time since a survey. And that's all public information as well, right? You can go on to Nursing Home Compare and you can see of the homes in your area, when was their last annual survey. You can probably get an idea of where you fall in line. That being said, there's no guarantees. They're allowed to survey, kind of whoever they want in their window, and everybody's in their window. So get ready for that. Hospital readmission rates, as I said, skilled nursing providers have been afforded a reprieve, I guess I'd say, from SNF value-based purchasing. Although it's sort of unclear how that's going to work. You were supposed to start reporting again back in July. What it sounds like is going to happen is that they're not going to exercise any penalties this year. Fiscal year 2022 is like fall of 21. So you won't see that readmission penalty hit your bottom line this year. However, when we are looking at readmissions in SNF value-based purchasing, it's all based on claims data. So when you get your fall of 2021 penalty, which is fiscal year 2022, it's probably actually looking at 2019 readmission rates. So while you might be getting a reprieve from the penalty this year, do not feel like you don't need to really focus on readmissions, because that's what's going to be looked at the next year. And you will get those penalties. So we get a break from the fine. We're not getting a break from the work. You all should still be very concerned about hospital readmission rates, and you should be marketing yourself with those. That's one of the biggest things that hospitals are looking for. Having a clear story on how you're managing readmissions and how you manage readmissions for different conditions is a really strong way to get in network. Customer satisfaction rates. There, as I mentioned, hospitals get incentivized with a program called HCAHPS, which is customer satisfaction survey, and they're rated 1 to 5 stars in HCAHPS. There are 4 questions in that survey that ask about the transition of care to the next setting. Now, this is specifically on Medicare patients, and so you all know when we have an elderly resident that had an episode at the hospital, very often when they're asked about that episode of care, they aren't discerning between what happened to them at the hospital and what's happening to them at your nursing home when they're answering questions about their satisfaction. So hospitals are acutely aware of this, and they know that if you are providing excellent customer service and you have high customer satisfaction, that's likely to be reflected in their HCAHPS scores. Community discharge, length of stay, some quality measures. Talk with your hospitals. They all might want different measures. Just be aware of what they're asking for. And then the last one is just, it's not a metric. It's being a willing participant in change. So I work with a lot of hospitals specifically in helping them to discern who should be in their network. And most hospitals really they really haven't reevaluated their network in a real way since 2015 when they started getting penalized for readmissions. I think 2021 is going to be the year that they take a good hard look again, and I want you all to be ready. But one thing that I see when I talk with care coordinators and population health managers at the hospital is that they have so many resources that they are willing to offer you, and we don't take advantage of them. They have educational sessions monthly with their network, and people don't show up. Even if things are crazy, just showing up and having that FaceTime, or they see, hey, they're paying attention to the lessons that we're teaching, the education that we're giving, they're taking advantage of the WOCNs that we can send out to do rounds for them. That then is, you are a participant in their network. And even if you didn't get a lot out of the education session in February of 2021 that they put on, somebody saw that you were there, and they saw that you're interested in bettering the quality as a whole. And that's going to go a long way too. So I want to talk a little bit about marketplace awareness, because 3-star isn't 3-star everywhere. 5-star isn't 5-star everywhere. So I want you all, when you go back to your teams, and we'll talk about what I want you to do when in a moment, think about what your strengths are as a facility in metrics, but also in care, and what are your weaknesses? And then how about your competition? And then look at where your referral source is struggling and succeeding. So all of you can go on to carecompare.gov, and that's the new CMS website where they have nursing home compare, hospital compare, home care compare. You can look up your referral source and you can see what their readmission penalty is. It's going to be anywhere from 0% to 3% of their Medicare dollars. So if it's at 3%, they're really struggling with readmissions. If it's at 0%, they're not. And I can tell you if it's at 0%, it's not an accident. They're not just getting lucky. They're actually really focusing on readmissions. And so we want to make sure that's part of our story that we're telling them. We really focus on that too. Their HCAP score, again, 1 to 5 stars, 1 is the worst, 5 is the best. That's how they're performing in customer satisfaction. But I wanted to show you just a little bit about how where you fall in your neighborhood makes a big difference. So I'm in Denver. It's a little earlier here for me than you, but it was a nice, bright, fresh start to the day. And when you look at Denver, you'll see if I was this facility over here, circled in blue, you'll see that the red are the 1 and 2 star facilities, yellow are the 3-star facilities, and green are the 4 and 5 star facilities. Like in this case, I'm a 4 or 5 star facility. I'm sitting pretty, right? I should have no problem getting in referral networks. And by and large, if you're a 4 or 5 star facility, you're going to luck into some census that way. However, if you look at Denver, almost everybody's a 4 or 5 star facility. So what am I doing when I'm talking to these hospitals over here to set myself apart from all of these other 4 and 5 star facilities? We all do pretty well on surveys. So what else can I bring to the table? And be aware of where you stand in the marketplace. Showing a different story. So our HealthStream headquarters were based in Nashville. Nashville's a little bit of a different story. Like here, I might be this guy that's a 1 or 2 star facility, and I might be feeling like, gosh, I just might as well not even try to get in the network. I don't know how I'm going to compete. But if you look, there's only 3 4 or 5 star facilities in Nashville, and almost everybody else is 1 or 2 stars. So just by nature of the population of that city, you are going to get census. How are you going to beat out these other facilities? What's your story to explain why you're a 1 or 2 star, and what's your plan to get better? So when you go in and you talk to your referral sources at the hospital, and I'm guessing you all know who those folks are, but if you don't at a certain hospital, look for folks with population health manager, care coordination in their title. Those are probably the folks that are making decisions about the post-acute care network. When you go in, make sure that you have a way to present your metrics that's very concise and metric driven. You should know your narrative. So if I'm that 1 or 2 star facility, I've got my story ready to tell. Really anticipate where are your weaknesses and what are they going to ask about, and how are you going to address or respond to those questions. Another thing that I'll tell you is don't skip the obvious. I can't tell you how often when I talk with hospitals and I'm like, well, you have all these vent patients, why aren't you sending anybody here? Well, we didn't know they did ventilator care. So even though you might think it's obvious, make sure that you know what are the services that you can provide that maybe they're not aware of. List them all out, you never know. And then be very consistent. So, this, and I talk a lot about QAPI, and this is one of the struggles that I see almost everybody have. It's really hard for me to tell you if you're doing better or worse in a certain area unless you're measuring it the same way and presenting it the same way in your meetings every time, right? Then we have a linear comparison, what we would call longitudinal reporting, where we can say, all right, from this point to this point, we did better, we did worse. The same is true of your hospital. So if you are going to present metrics, do it the exact same way every time, and do it in a way that's really easy for them to understand without you there to explain it. Because chances are you're going to come in to have this conversation, and if you're lucky, you'll get a half an hour of their time to have it. But they're not going to really remember or think about where you are in the network until a week down the line when a specific patient is coming through, or when they're having that meeting with their leadership team to decide who's the preferred network and who's not. So could they understand your metrics and what you're telling them about you without you there to explain it? So here's our first strategy that I want you guys to go back with your teams and consider. So management teams, your quality teams, those are all good places to start here. But what are our strategies on how we increase our revenue and reduce our penalties in 2021? How are we going to get into that network? All right. So Wendy, I thought I'd pause. This is kind of the first section to see if there's any questions in the questions section. For all of you that jumped on a little late, everybody's muted, but there should be a questions panel in your control panel for GoToWebinar. If you type in those questions, Wendy will ask them for me and I'll get you some answers. Okay.
We don't have any questions at this time, but we certainly are open to questions. So if you do have any questions, please type them in the panel on the right-hand side of your screen.
Perfect. And we'll leave time for questions at the end too. Okie doke, let's go on to our second trend that I think will help you to survive and thrive this year is the new presidential administration. So what's going to happen? What can we expect? So I'm going to give you another quote. This one's from Andrew Hirschfeld from Bloomberg, and he says, value-based care appears poised for takeoff with two key factors fueling its rise: lessons from the pandemic and a Joe Biden presidency. When we talk about presidential administrations and healthcare, this ceases to really be a political conversation at all. There are pros and cons to each, but it's really predictable how they treat healthcare. And so that's what we're going to talk about, is how will this administration likely treat healthcare. So when we have Republican administrations, what we typically see is that they are less inclined to invest in social programs. That's one way that they try to make cuts, right? They don't really fund Medicare. That's where we typically see cuts there. Social Security, gets a cut. They're less inclined to invest in those types of programs. So we typically see less money. However, we also typically see less regulation. There are less rules to follow and less oversight, which means less emphasis on survey. And we saw this with Donald Trump. He had a 1 in, 2 out rule. If you wanted to add a new piece of regulation, we're getting rid of 2 others. We saw it, frankly, with the final rule where, had COVID not hit, things could have changed a little bit. With the final rule that was supposed to be fully implemented in 2019, we got a delay, and we had a proposed rule out that was proposing kind of easing up on some of the regulations. So instead of doing your facility assessment every year, you were doing it every 2 years. And, the QAPI requirements got a little bit less stringent. That proposed rule never was finalized. It's unlikely to now. So the final rule will probably stand as is. If you ever want some nice nighttime reading to put you to sleep, you can reread that. But that's typically what we see in a Republican administration. So as we go into a Democratic administration, we see the opposite. We see that they're more inclined to invest in social programs, which is where we are going to see this basket increase in payment, which is great. We're going to see more reimbursement, which is good. It puts us in a better financial situation. But you also tend to see that they will increase oversight and they will increase regulation. That's what you need to be ready for, is an increase in surveys. In any Democratic administration, you would see that. But in the aftermath of COVID, where we took such a public beating as an industry, there's a lot of public outcry for reform. And so, PHCA and Wendy's colleagues there and the American Healthcare Association nationally actually put together our own proposed reform plan. We know that somebody's going to come at us with reform. They suggested their own reform plan. And a lot of it is, it makes sense, and it makes you feel a little self-righteous, where they say, if you would like us to provide the most excellent care for this frail population, you've got to pay for it, and you've got to allow us to staff it. Like that's where you're going to see a difference in quality outcomes. But you can't underpay this industry and expect miracles. You can't be shocked that when you have frail elderly with 8 to 10 comorbidities living in almost a dorm-like situation, all packed together, that we had the bulk of the infections and the bulk of the deaths. That's not that surprising based on how we are today. So we shouldn't see Medicare cuts, which is good, but we need to be prepared for more oversight, right? So healthcare is one of the most regulated industries in the US. The Bureau of Labor and Statistics projected that compliance officers are going to grow by 8% through 2026. So what we need to be ready for is that increased scrutiny, both in terms of surveys and in terms of fines. So realistically, your annual surveys were supposed to start back up last November. I have not heard of any state where that really happened so much. I'm hearing almost every state where it's last month and this month that they know they're starting back up. They've heard the rumblings. And many facilities haven't had a survey in over 2 years. So not only are we going to see them come back, we're going to expect them to come back pretty hard. In terms of fines, we can expect to see increases there as well. So from April to September of last year, so surveys are paused, our annuals are. The only surveys that are happening are those COVID-19 specific surveys for nursing homes. And from April to September last year, we saw $15 million in fines. Just to give you an idea, in a typical calendar year with annual surveys and complaint surveys, we only see 5 million. So we want to avoid getting those fines. The last thing that you need is to be losing money because of a survey penalty. When we look at SNF value-based purchasing, as I said, you are not going to see those penalties this year. You're also not going to see the incentives this year. But the way that this value-based purchasing program works, and as I said, we can expect to see these value-based purchasing programs expand under Biden, is that it's designed to be a pay-for program, meaning this is not ever going to cost the government more money than it will to incentivize you. So this is the way it's designed. It's always going to keep this ratio. It's designed to penalize about 70% of nursing homes. So the way it works is it's a withhold. And the danger in that is we don't ever see the money. So it's almost like we don't realize it's missing. It's a lot like investing in a 401k. When they take it out of your paycheck, you don't really miss it. And then you're excited when you have some savings when you retire. This kind of works the opposite. For every Medicare dollar that you build, they're keeping 2 cents of that and they're holding it in a bucket. And every nursing home in the United States has a goal readmission rate, and that rate is risk adjusted. So if you're taking on harder residents than the facility down the street, you're probably allowed a higher rate of readmission than they are. But you've got to meet or beat that rate. If you meet that rate, you get that 2% back. And you can see that that's what we call our neutral folks. Only 5% got their 2% back. If you beat that rate, you can potentially earn up to 1.8% more back. So these 25% got their 2% back, plus they earned another almost 2%. The rest got penalized some portion of that 2%. So the danger here is that, let's say that I I didn't meet my rate, but I wasn't horrible, right? I only ended up getting penalized 1%. I get reimbursed that other 1% that they withheld. So it almost looks like I'm getting money when really I still lost 1%. So be aware of this. It's a tough thing to kind of keep track of because it's not money that you see. You're not writing a check back to them. So it doesn't feel like you're losing money, but you are. This is a great way that we can gain revenue in a time where we are stretched to the limits. So the fallout here, there's going to be increased audits, more surveys, potentially new or increased regulatory requirements. I will say that they potentially, so they're going back to the regular survey, but I could still see that they ask for that COVID self-assessment. So I would still be conducting that self-assessment for a time, but be prepared for that full survey process. So what does that mean? It's been a while. The things that they ask for right when they walk in the door, your facility assessment, which is taking a look at who it is that you have taken care of in the last year. And then your leadership team makes the decision on what resources are necessary to care for them. Well, we had a lot of changes in the last year. Have you updated that facility assessment? Your facility assessment is also where your emergency preparedness plan is. I'm sure that we've all looked at that at this point, but do we have that edited, ready for showing? Your QAPI plan is also going to be asked for. Just a word to the wise, I see a lot of QAPI plans, and to be clear, your QAPI plan should be a description of how you are conducting QAPI activity. It should be a written defense of how you're meeting each one of those 5 elements of QAPI. It should not, under any circumstances, include your QAPI findings, your QAPI data, or your PIPs. Do not have that in your QAPI plan. You are just airing dirty laundry that you do not need to air. But do you have those things ready? And then the other piece of fallout is that there's going to be an increased focus on value-based purchasing. There was just an announcement the other day that they're going to add, they're adding more metrics to value-based purchasing that you'll get incentivized for or penalized for. So pay attention to that. I know PHCA will do a great job of keeping you updated as to what those are specifically, how you manage them, and when they're coming out. So second question I want you to take back to your teams. We know Democratic administrations lean towards greater reimbursement, but more oversight. Basically, are we ready for survey? Because it's coming, and what do we need to do? Are all of our final rule type documents, have those been updated, or have we just not really thought about them in a year? Understandably so. Now's the time to start thinking about them again. Okay, so our last section, and then we'll open it up for some questions. Lasting change. So what are some shifts that have happened during COVID that I would expect will not revert back post-pandemic, that we're going to just really feel the repercussions from for a while? So this is an intensive care nurse. There came a point where I told myself I have to find a different job. The stress from this is really making me physically sick. And I know you all have seen this. We had staffing shortages constantly before COVID, and we're seeing it more and more after. We're going to see compounded staffing shortages, and almost in a worse way, which I'll talk about in a little bit. And then I think that you're also going to see an increased reliance on telehealth, which we haven't talked a lot about, but telehealth, we've been set up to do telehealth for years. Like, think about how long you've been using FaceTime to talk to your family. The reason that never really took off is that there was no reimbursement for it. So there's no way for you to bill for that. And, we're not in the business of providing services and not being able to bill for it. That's fee for service. Well, with COVID, the CMS passed regulation in record time to get telehealth paid for. So you all can bill for telehealth, physicians can bill for telehealth, hospitals can, and it is a safer way to provide care. And frankly, it's a more efficient way. You can actually get a lot more patient time in using telehealth than you can with straight face-to-face meetings. So I would expect that stays. But let's talk a little bit about the more immediate and pressing need is our staffing problem. Right now, we've got 1/3 of nursing homes have a shortage of direct care workers. We've got 35% average DON turnover. And I think you all know this. What we're seeing is we have people that are dedicated to our industry and to your organization, and they say, I am here for you. I'm going to see you through this, but this is about it for me. This was pretty rough, and I'm going to be retiring. So a lot of our nurses that were close to retirement are taking early retirement, and that's problematic. I mean, I know DONs who have forgotten more about medicine than physicians now. And we've been leaning on those resources to handle things like our quality, our learning, competency and training, the operational side of running a facility. And we're starting to get caught having put all of our eggs in that basket. It's almost like your computers are walking out the door with all of those files, all of that knowledge. And that's going to be a problem for us. So we're going to see people walking out. I'd also say on the better side, I think that you're going to see an influx of people getting into healthcare that weren't there before. And we saw it in 9/11, that right after 9/11 happened, police forces, firefighting organizations were just flooded with applicants that really wished that they could have contributed and they could have done more. I think we'll see the same thing. I think that we're going to see people wanting to get into healthcare. But what that means for us is that we're going to have a way to onboard people quickly and consistently, at least for the short term. But I would say this is another lasting change. You really need to look at remote learning, online learning that you can do, which is going to be safer in terms of infection control. But then also, how do we have that in tandem with in-person learning? Because very often online learning isn't enough for a new CNA to feel comfortable to perform a certain function, or for a nurse to go insert a catheter if that's not something that she does every day and it's been a month and a half. Do we have a way to refresh really quickly so that those services are performed consistently and with quality? Now would be a time, because we have so many folks exiting that had so much knowledge, that we start to look at systems that can help. And this would be looking at your vendors through PHCA. Are there places where we can automate functions that maybe we had a person doing before? So if your DON was the person that was really in charge of competency and learning, is there a system that you can use to depend on to manage all of that for you? Systems to manage your risk analysis. There's a lot of great MDS scrubbers and risk analytics systems. I mean, your EMRs do a ton these days. Systems to manage your quality and your survey readiness. Those are things that you want to take a look at. How much is the cost to invest in a system versus where am I without it, and do I have people to run that? And if I could invest in a system, could it give my people time back at the bedside? I'll tell you, I mean, like, we think about competency and learning all day, every day. So we could take some weight off your shoulders, and there's a lot of vendors that can do that for you. Not that you need to call vendors for every little thing, but take a look at what you could maybe outsource at this point. And then we talked a little bit about telehealth. I guess I got ahead of myself there, but we have seen a 154% increase in telehealth in 2020. So take a look at telehealth as well. I think those are good systems to take a look at. Where can it potentially impact my bottom line and increase the quality of care that I can provide? So the last question that I want you to go back to your teams with would be just that. What are the areas where we can outsource, or that we can spread internally across multiple disciplines so that turnover isn't going to halt progress for us? Because unfortunately, you're not going to get a free pass when somebody leaves that was performing a function for you. So how are we going to anticipate the staffing shortage and the high level of people that are going to be leaving, instead of just react later? How can we be proactive and take a look at those things? So I just want to wrap up before we open it up for questions, Wendy. I mean, you guys know it's been a rough ride. All of us have lost a lot of money. The way that we're getting paid is likely to shift and change a little bit. There's more oversight. A lot of people that handled functions for you in your home could leave. But I think that there are very real ways that you can strategize to come out of this successfully. So have a strategy in place on how you're going to be proactive in getting into that preferred network. If you filled one more bed a year from a hospital, and I'm talking a blended rate. So if we think that Medicare's 500-ish, Medicaid's 170-ish, let's say that we're looking at 300 to 350 a day blended rate. If you fill one more bed a year, it's $125,000. That's a lot of money. If we can increase that to 2 beds a year, we're really starting to come out of this successful and healthy. So look at your strategy to get into those referral networks. Take a look at where value-based purchasing is likely to go. That's a way that you can make more money if you perform well. Do we have an emphasis on that in our quality program? And then lastly, are we looking at places that we can outsource that can potentially handle some burden for us to get us through this staffing shortage? So Wendy, that's all I had. I wanted to put my information up on the screen. So if anybody's shy, they don't want to ask a question in front of everybody, my email is on there. My cell phone number is on there as well. But at this point, Wendy, I thought we could see if there were any questions in the chat box.
Great. Thank you, Ellen. That was a lot of information today, but a lot of things to think about and consider. And as we're coming out of this, all things that, again, important to consider and put into play. So we are open for questions at this time. If you have any questions, please type them in the chat box. And while we're waiting for questions, I just want to remind everyone that we have webinars, weekly webinars for the next couple weeks. Next week, we have a webinar on visitation and reopening. So please look for the information on that and sign up for it. We have sales and marketing webinar the last week of the month. And then we have 2 legal webinars in May. One on, any kind of COVID liability that could potentially happen. And also one on HR policies and how they may be changing as a result of COVID. And then after that, we have our Assisted Living and Personal Care Home Summit, saying that there's a leadership focus this year, so it really could be applicable to anyone, on the skilled side as well. We think we have a really robust, exciting program with some different speakers, and we're very excited about it. 10 CEUs are offered, and take a look at that agenda and consider, signing up, or if you know somebody else who would benefit from it, pass it along. All right, Ellen, I think you did a bang-up job here. There are no questions. I don't know if everybody's just glazed over with what comes next. Or,
well, I hope nobody's too overwhelmed. It's nothing that you all don't know how to do. It's just kind of a renewed focus on some of these things. And yeah, please, Wendy, feel free to have any of your membership reach out if they have questions on how, or if they need help looking at kind of their position in their network. I'm happy to help with any of that.
Terrific. Yeah, I will be sending in the follow-up. I'll have Ellen's contact information in our follow-up email, hopefully either later today or tomorrow. So take a look out for that. And again, don't forget to complete the survey. Today's webinar has been recorded and will be made available on the PHCA website. And again, be sure to check into our, our webinars. We are scheduling into July right now, so there's a lot of stuff available and a lot of good information. Thank you again to Ellen for today's presentation, and I just want to wish everybody a great remainder to your day. Stay well, everybody.